Hello, everyone, and welcome to today's webinar. The topic of today's webinar is Subscapularis integrity and Posterosuperior cuff tear severity affect scapular impingement and joint stability in reverse total shoulder arthroplasty. My name is Divyak Chandar, and I work as a sales engineer here at Anybody Technology. Today, I will be the host of this webinar, and I'll be joined by my colleague Christopher Iverson during the Q&A session in the end. In the Anybody webcast series, we host a variety of presenters who have used Anybody modeling system in different applications. In today's webcast, I am very pleased to introduce our presenter, Dongwhan Lee, who is a PhD candidate at Sogang University. Lee will present his recent work on the interaction between reverse total shoulder arthroplasty, RTSA designs, subscapularis integrity, and posterosuperior cuff tear severity, and will talk about how musculoskeletal model simulations can inform surgical planning. Lee's research is already published in Bone and Joint Research Journal, and you can go and check out the paper if you would like to read the very details of his work. The presentation will start in a few minutes or so, but just before we start, I'll give a general introduction and overview of Anybody modeling system for those of you who are unfamiliar with the software or musculoskeletal modeling and simulations in general. First of all, I'd like to draw your attention to the control panel. The control panel appears on the top right side of your screen. You're welcome to submit questions and comments via the questions panel during the presentation, and we'll try to address the questions at the end of this webinar. In case we do not get to answer all your questions, we will try to do so by email within a reasonable time. So let's begin by having a look at what Anybody modeling system actually is. Anybody modeling system is a software that allows you to do musculoskeletal modeling and simulations. As input, it takes motion data and forces, and as output, it calculates internal body loads such as joint reaction force, muscle forces, muscle activity, and metabolic energy. Anybody is used in a wide variety of areas and applications, and a few examples of these are movement analysis, product design optimization, sports optimization, orthopedics and rehabilitation, ergonomics with and without assistive devices such as exoskeletons, and in the automotive industry. The typical workflow in Anybody could look like this. You provide the recorded motion data as input and use the body models which you or others have built. And then you can optionally provide some kind of environment, which could be a special type of equipment or, for example, an exoskeleton. Then you can use Anybody to combine these things and run the inverse dynamics simulation, which solves the muscle recruitment problem. This basically means that we go from motion to calculating the internal body loads and interaction with the environment in some cases. You can then output the results and use it for post-processing with, for example, some kind of finite element tool. But many users also close the loop completely by doing some kind of design optimization and then run this cycle multiple times. This actually brings me to the end of the introduction, and I'll hand over the word and presenter role to Lee instead.
Okay, thank you. Thank you for the introduction, Dave. Hello, everyone. I'm Dongwhan Lee from Sogang University Biomechanics Lab, Korea. It is an honor, and I'm very excited to share my research on shoulder biomechanics using the Anybody modeling system. To provide some context, I'd like to briefly explain what total shoulder arthroplasty entails before we dive into reverse TSA. And Charles Neer pioneered modern anatomic TSA in the 1970s. As shown in Figure 1, this conventional approach focuses on replicating the shoulder's natural anatomy. The anatomic TSA has been shown to achieve better clinical outcomes in patients with chronic arthritis and an integral rotator cuff. The reason for this is that anatomic designs depend on joint compression generated by the rotator cuff. So when the rotator cuff is torn, the joint loses stability, which is exactly why we should consider reverse TSA for more complex cases. Reverse shoulder arthroplasty, or RTSA, has become the standard treatment for conditions like cuff tear arthropathy, As we can see in Figure 2, RTSA reverses the ball and socket geometry by placing the gland sphere on the scapula side. This design improved joint stability compared to the Anatomic TSA. The mechanical advantage here is that by medializing and distalizing the center rotation, the system can recruit more fibers of the deltoid to act as abductors. This allows patients to regain arm elevation even when their rotator cuff is massively torn. However, RTSA is not a perfect solution for every case. Even with this design, massive rotator cuff tears can still increase the risk of joint instability or dislocation. The risk of exactly why we need a deeper understanding of how different cuff tear patterns affect joint stability in RTSA. As shown in Figure 3, rotator cuff tears can vary, ranging from partial to full thickness tears. Furthermore, in the context of RTSA, there is an ongoing clinical debate regarding the subscapularis. Surgeons often face the decision of whether to repair the subscapularis or to leave the tear during surgery. Now, let's look closer at the specific rotator cuff conditions we encounter in clinical practice. Specifically, I'd like to focus on the supraspinatus first. This muscle is known as a primary shoulder abductor. However, in most RTS patients, it is already completely torn. Furthermore, even when the supraspinatus remains intact, it is often excised by surgeons to enhance glenoid exposure, making it easier to prepare the bone for the implant. Biomechanically, this tear increased muscle forces in the subscapularis and infraspinatus. Next is the infraspinatus. As a primary external rotator, the infraspinatus provides a transverse force couple with the subscapularis. This force balance is essential for maintaining joint stability. Therefore, this tear increases the risk of joint instability. In clinical cases, the infraspinatus often present with either a partial or a full thickness tear in RTSA patients. Finally, let's discuss the third muscle of interest. As a primary internal rotator, the subscapularis is the anterior counterpart to the infraspinatus. Together, they maintain the transverse force couple that I mentioned earlier. As shown in Figure 4, this force balance is what keeps the joint centered and stable during rotation. In a clinical setting, there is some significant debate regarding the management of this muscle during RTSA. After performing the tenotomy for a surgical approach, surgeon must decide whether to repair the subscapularis or leave it torn. However, various outcomes following subscapularis repair have been reported to depend on implant design. As shown in Figure 5, medialized RTSA is characterized by a medialized glenoid, meaning there's no offset from the gland surface. It also features medialized humerus with an inlay configuration. This is often referred to as the traditional grandma style design. From a clinical perspective, medialized RTSA is known to be more prone to dislocation than lateralized RTSA. Therefore, several studies suggest that subscapularis repair in medialized RTSA is required to reduce the risk of joint instability or dislocation. On the other hand, as we can see in the Figure 6, lateralized RTSA takes a different approach. It incorporates a lateral offset from the glenoid surface and utilizes a humeral-only configuration. This shift lateralizes the humeral component to enhance joint compression. The biomechanical rationale behind this design is to improve joint stability by enhancing joint compression. However, this benefit reignited debate over the necessity of subscapularis repair in lateralized RTSA. Based on these controversies, we arrived at two primary research questions. First, why exactly is the effect of subscapularis repair still debated in lateralized RTSA? On one hand, some studies suggest clear pros such as reduced impingement and subluxation, as shown in Figure 7. On the other hand, other studies show cons, stating that there is no significant effect on joint stability or dislocation rate. This issue leads to our second and perhaps more critical question. Did prior studies account for the integrity of the remaining cup? In many clinical trials, the integrity of the other rotator cup is often overlooked. However, as we discussed earlier, the shoulder stability relies on the delicate force balance. For example, if the simpress platelet is torn, the biomechanical role of the subscapularis repair may be altered. However, the influence of subscapularis repair across different cup-tear severities remains unclear in both medialized and lateralized RTSA. This fundamental gap in our knowledge is what we aim to address in this study. We want to determine how these repair outcomes vary depending on both the implant designs and the underlying cup-tear severity. Therefore, the purpose of this study was to compare the effect of medialized and lateralized RTSA on impingement stress and joint subluxation based on subscapularis integrity and rotator cup tear severity. The overall simulation process for the musculoskeletal model is illustrated in this workflow. First, each musculoskeletal model for both medialized and lateralized RTSA was developed by incorporating its prosthetic bone geometry into a previously validated anatomic shoulder model. Second, 12 human in vivo experimental datasets were used as consistent input for both RTSA model. Third, segment scaling was performed using parameter identification to minimize discrepancies between model and experimentally recorded macro trajectories. Fourth, the lateralized RTSA model was validated by comparing impingement stress and joint subluxation against results from a validated finite element model. Finally, impingement stress and joint subluxation were compared between the medialized and lateralized RTSA models under both subscapularis repaired and subscapularis torn conditions across 3 stages of rotator cup tear severity. In this study, 12 male experimental datasets collected during 45 degrees of external rotation were used as input to the musculoskeletal model. As shown in Figure 9, we developed 2 distinct RTSA models to represent the primary design philosophies. For the medialized RTSA model, we used the Lima SMR system from Italy, which features traditional medialized glenoid and medialized humors. In contrast, for the lateralized RTSA model, we used the Corrales liver shoulder system from South Korea, which incorporates the lateral offset from the glenoid surface and only design which we discussed earlier. Within this 2-implant environment, we specifically control the conditions of the subscapularis. The subscapularis repair model represents a state where all muscle bundles are intact, while the subscapularis torn model simulates a condition where all bundles are completely torn. To calculate the impingement stress between the scapula and the humeral component, we utilize the force band kinematic method within the anatomic modeling system. This approach allows the joint kinematics to be determined by the actual force balance and contact mechanics rather than just prescribed motion. The pressure module, as shown in equation 3, is the core parameter for implementing this method. In this study, we defined a pressure module of 3.5 5 times 10 to the 11th Newton per cubic meter for the medialized RTSA model, and 3.93 times 10 to the 11th Newton per cubic meter for lateralized RTSA model. For more detailed values of these FDK parameters, please refer to our study in bone joint research. Finally, using this method, we can calculate the impingement force and contact area. Thus, the impingement stress is obtained by dividing the force by the area, as shown in equation 4. To compare the effects of medialized and lateralized RTSA, we focus on two primary biomechanical outcomes. First, we calculate the scapular notching-related impingement stress measured in megapascals. As we discussed in the previous slide, this stress is obtained by dividing the contact force by the contact area. By quantifying this, we can predict the mechanical severity of the impact between the scapula and the humeral component. Second, we measure joint subluxation in millimeters. This metric represents the dynamic stability of the joint. We quantified it as the square root of the three-dimensional joint translations between the center rotations of the gland sphere and the humeral component. To validate our model, we compare impingement stress and joint subluxation against results from a validated finite element model. The reference study used the right toner lateralized RTSA and simulate a 45-degree shoulder external rotation. Now, let's look at the results of our model validation. As shown in figure 12, our simulation for the lateralized RTSA predicts a range of peak impingement stress from 21.4 to 45.7 megapascal across various cup conditions. This range encompasses the previously reported value of 25 megapascal, which support the validity of our musculoskeletal model. Next, we validate our model using the second metric of peak joint subluxation. As shown in figure 13, our simulations for the lateralized RTSA predict a subluxation range of 1.1 to 5 millimeter across various cup conditions. When considering the mean and standard deviation of our data, the predicted joint subluxation was within an acceptable margin of the reported 7.6 millimeter from the literature, supporting the model's validity. I would like to note that this direct comparison was focused on the lateralized RTSA, as comparable reference data for the medialized RTSA is currently limited in the literature. However, because both the medialized and lateralized RTSA models were developed using the same musculoskeletal framework, the validation of the lateralized RTSA model provide high confidence in the predictive accuracy of the medialized RTSA model as well. Overall, we believe our model reliably predicts both scapular notching-related impingement stress and joint subluxation during external rotation. Now let's move on to musculoskeletal simulations. We simulate medialized and lateralized RTSA models under subscapularis repair and torn conditions across three stages of Posterosuperior cup tear severity. Stage 1 represents isolated supraspinatus bundle tears. Stage 2 represents stage 1 with the superior bundle tears of the infraspinatus. Stage 3 represents the complete supraspinatus and infraspinatus tears. We perform a three-way ANOVA to assess the effect of RTSA design, subscapularis condition, and cup tear severity on the impingement stress and joint subluxation. Then we conduct post-operative tests to compare them. Here are our results. Table 1 provides a comprehensive comparison of peak impingement stress and joint subluxation. To make this complex data easier to follow, I will break it down step by step. First, I would like to focus on the overall comparison between the two RTSA models. If you look at the columns for the medialized and lateralized RTSA, a very clear trend emerged immediately. Across every single scenario, we observed that both peak impingement stress and joint stabilization were consistently higher in medialized RTSA. For instance, in the worst case scenario of the stage 3 with torn subscapularis, the medialized RTSA reached a stress of 80.2 megapascal and the subluxation of 11.3 millimeter, whereas the lateral RTSA stayed much lower. As summarized at the bottom, peak impingement stress and joint stabilization were consistently and significantly higher in the medialized RTSA than in the lateralized RTSA. This suggests that implant design itself is a primary factor in maintaining joint stability and reducing mechanical stress. Following the design comparison, let's now investigate the specific impact of the subscapularis condition on these outcomes. As highlighted in red, we compare the impingement stress between the subscapularis repaired and torn conditions within the two RTSA models. In both medialized and lateralized RTSA model, repairing the subscapularis led to a significant reduction in peak impingement stress across all stages. As summarized at the bottom, subscapularis repair significantly decreased impingement stress in both medialized and lateralized RTSA models. Then we compare the subluxation. In both medialized and lateralized RTSA models, repairing the subscapularis led to a significant reduction in the peak joint subluxation across all stages. As summarized at the bottom, subscapularis repair decreased joint subluxation in both medialized and lateralized RTSA. Now, let's move on to our focus on the cuff tear severity. As highlighted in red, let's look at the stage columns alongside the peak impingement stress for the medialized RTSA model. Compared to stage 1, the peak impingement stress in the medialized RTSA significantly increased by 19.7% and 16.7% in stage 2. The most dramatic change, however, occurs in stage 3. Once we reach a complete tear of both supraspinatus and infraspinatus, the stress levels surge by 55.6% and 59.9% for the repaired and torn subscapularis conditions, respectively. This shows that the loss of the posterior counterpart result in increased mechanical impingement. Moving on, let's perform the same analysis for the lateralized RTSA to see how it responds to progressive tear severity. As highlighted in red, we observed a similar patterns of increasing impingement stress as the tear progresses. Even in lateralized RTSA, the loss of cuff integrity led to a clear mechanical disadvantage. Now, let's move on to joint stabilization. We will first look at how the progression of cuff tear severity affects the medialized RTSA model. Compared to stage 1, the peak joint stabilization in the medialized RTSA significantly increased by 11.7% and 18.4% in stage 2. This indicates that even a partial tear of the infraspinatus begins to compromise joint stability. The progression to stage 3 led to a critical increase in joint subluxation for the medialized RTSA. This confirms that the integrity of the infraspinatus is a dominant factor in maintaining joint stability in medialized RTSA. Next, let's observe how the lateralized RTSA respond to the same progression of cup-tear severity. As highlighted in red, although the absolute values of subluxation are lower than those of the medialized RTSA, the relative increase in subluxation as the tear progresses is more pronounced in the lateralized RTSA. As summarized at the bottom, the increases in lateralized RTSA were as high as 239.5% in stage 3. This suggests that while lateralization provides a superior baseline for stability, its mechanical performance is highly sensitive to the integrity of the infrastructures. To wrap up our results section, we perform a final statistical analysis to evaluate the interaction effects between our primary variables. As summarized at the bottom, we found significant interactions between the RTSA design and cup tear severity for both peak impingement stress and joint subluxation. This means that the effect of tear progression is not uniform across different RTSA designs. Specifically, as the tear severity increases, the mechanical response of the lateralized RTSA is highly sensitive, showing a much steeper change in relative subluxation compared to the medialized RTSA. So taken together, while the lateralized RTSA is more sensitive to tear progression, it consistently maintains lower absolute subluxation levels compared to the medialized RTSA. This study demonstrates that lateralized RTSA is more effective at reducing impingement stress and joint subluxation during external rotation. Furthermore, we found that subscapularis repair further enhances this benefit in lateralized RTSA across all posterosuperior cup-tear conditions. According to previous research, joint instability is commonly associated with impingement and arises from an unbalanced force couple due to anterior or posterior cup deficiency. Therefore, our findings support lateralized RTSA with subscapularis repair as an effective strategy for mitigating impingement and improving joint stability. In conclusion, lateralization and subscapularis repair in RTSA can mitigate impingement and improve joint stability in patients with posterior superior cup deficiencies. These findings can inform surgical decisions regarding implant design and subscapularis repair to reduce the risk of scapular impingement and joint subluxation. Finally, I would like to share some upcoming events and a brief update on my professional journey. I'm excited to announce that I will be presenting our latest findings at the ORS annual meeting later this month on March 28th, and at the 10th World Congress of Biomechanics in Vancouver this July. If any of you are attending these conferences, I would be delighted to connect and discuss our work in more detail. As I'm scheduled to complete my PhD program this August, I'm currently looking forward to the next chapter of my career. I'm deeply interested in exploring new research opportunities and potential collaborations where I can further apply my expertise in shoulder biomechanics. My contact information and LinkedIn profile are listed here. I'm always open to discussing future research positions or any academic inquiries you may have. Thank you very much. Thank you very much for your time and attention today. I'd now be happy to take any questions.
Just before we go to the Q&A session, I'd like to say a few words about our online resources and upcoming events. If you want to know more about Anybody Technology, you can go and check out our website, anybodytech.com, where you can find different events, special dates, and previous webcasts. You can also check out anyscript.org, which is our community website for people using Anybody. Here you will find multiple online resources such as our wiki page, several blog posts, and links to the repository sites. Our forum is also located on anyscript.org, and here you can ask questions and get help from some fellow Anybody users. We also participate in conferences from time to time. So Anybody Technology will be present at Orthopedic Research Society 2026 in USA from March 27 to 31. And at the World Congress of Biomechanics in Canada in July. You are welcome to visit us if you're going to be there. And of course, you can also see Lee while he's there at these events. To end this presentation, what I would like to mention that we maintain a publication list of papers using Anybody modeling system and a library of previous webcasts. These are great resources if you want to get inspiration on how to use Anybody. This brings us to the Q&A session, and we will read some questions from the audience.